Module 3, Connective Tissue Disorders. Required reading for this section is going to be Chapter 20 in your Med-Surg textbook. Again, we're coordinating care for patients with connective tissue disorders. And let's get started. Connective tissues. So connective tissues are all throughout our body. They cover, support, and protect our structures in our body and our organs, and they aid in movement. So our connective tissues include bone, cartilage, tendons, ligaments, lymphatic tissue, and bone marrow. What we're talking about in this chapter is going to be related to bone, cartilage, tendon, and ligaments. So we're going to start off by defining the term arthritis. And you see the umbrella here, so that means that arthritis is an umbrella term. So all of the different conditions we're going to talk about have some form of arthritis, which is joint inflammation of one or more joints. So you can see in the picture we're going to talk about osteoarthritis, rheumatoid arthritis, gout, fibromyalgia, lupus, and we're also going to talk about scleroderma. Our first condition we're going to discuss is osteoarthritis, or OA. So OA by definition is a slowly progressive non-inflammatory disorder of the diarthrodial synovial joints. It is the most common form of arthritis in this country. There are millions of people that have it, and it's the leading cause of chronic disability. So what is it? So this is a slowly progressive condition. So progressive means it's going to worsen over time. It's slow, so you're not going to wake up one day and you have osteoarthritis. It's going to go slow over time. And it's considered a non-inflammatory disorder, so we're not going to have all of those hallmark signs and symptoms of inflammation. And this affects our diarthrodial or synovial joints. So what are those synovial joints? If you look here in this picture, these are all the different types of synovial joints we have. They are the mobile joints, the joints that allow us to move. So our vertebrae, our wrist, our elbow, our shoulder, our hip, our knees, our ankle, those are all synovial joints. With osteoarthritis, the cause of this is wear and tear. That's going to be the main cause. So if you think about it, we all experience some wear and tear over time because we grow up and we work and we do things, physical things, so we're using our joints. That is normal wear and tear. So why do some people develop osteoarthritis? So osteoarthritis develops when you are doing some type of repetitive motion that puts extra wear and tear on those joints. So for example, your occupation, if you squat a lot, if you reach a lot, if you're using a certain joint over and over, then that is going to develop osteoarthritis. If you were injured, maybe you were in a car accident and you hurt your knee, that injury can progress and develop into osteoarthritis. Osteoarthritis, you become higher risk as we get older. So older age does not cause osteoarthritis. It just puts you at higher risk for osteoarthritis. And that's because over the years, you have more wear and tear. So you're more likely to develop something like that as we get older. So what is osteoarthritis? So we're talking about the synovial joint, and synovial fluid is what kind of cushions the two bones that are coming together to make the joint so that they move freely, kind of like oil, lubrication. And then we have this articular cartilage there that also helps to support that joint. And remember, when the two bones come together, they're not really touching each other. There's always a gap. So over time, when there is breakdown of that articular cartilage, that cartilage becomes soft and less elastic. So it is less able to resist that heavy wear and tear, the use. So the body does realize this is happening, and it tries to repair that cartilage, but it just can't keep up with the destruction of what happens in osteoarthritis. So as the collagen there and that structure changes, that articular surface becomes cracked and worn. The cartilage surrounding that becomes thinner, and the cartilage at the joint edges become thicker. And then these little osteophytes form. Again, this is the body trying to fix itself. The joint surfaces become uneven, and it affects the distribution of stress as we use the joint, and it causes reduced motion. So this can affect mobility. So even though this is a non-inflammatory disorder, you can get inflammation eventually as our white blood cells try to get rid of the small pieces of cartilage that have broken off from that joint surface. And these can actually cause some inflammation. So these changes, all those changes I just talked about, cause pain and stiffness in osteoarthritis, and that's early on in the disease. But later, once that articular cartilage is lost, then those bony surfaces, those two joints, are going to rub against each other, and that can be very painful. Okay, so let's recap that pathophys that we just talked about. So with osteoarthritis, we're going to have gradual loss of articular cartilage. We're going to have these bony outgrowths that we're going to refer to as spurs or osteophytes at the joint margins. That's our body trying to repair the site. There's going to be unprotected bone where those two bones will eventually start to rub up against each other. There's going to be deterioration of the joint function. This is progressive, which means it's only going to get worse, and there is no cure. And the most common joints that are going to be affected are going to be those joints that are the weight-bearing joints, the knees, the hips, the feet, and the lumbar spine. It could also affect the cervical spine and the fingers, but that's less common. So sometimes even the shoulders and elbows are involved, and that could happen from trauma, like an accident, or maybe sports. Maybe you're a golfer or something like that, and you're repeatedly using like your shoulder joint, then that can also cause osteoarthritis. So risk factors. We talked about why age is a risk factor. Female sex. So once a female goes into menopause, there is decreased estrogen, and that may be the reason why it contributes to more females having osteoarthritis in aging women. Obesity is a modifiable risk factor, and whenever you hear modifiable risk factor, that means you're going to have to include that in your teaching for those patients. And it makes sense that obesity is a risk factor because of all of that extra weight on those weight-bearing joints. So obesity really contributes to those hip and knee osteoarthritis. And then we talked about occupation. And then medications can also affect osteoarthritis. Corticosteroids can kind of leach calcium out of the bones, and it can lead to other bone issues, and osteoarthritis is one of them. Moving on to clinical manifestations. So osteoarthritis can be mild to significant disability. So there's the whole spectrum of pain, and the pain will progress over time. So very important to remember, in osteoarthritis, pain is relieved by rest. So you're working during the day, those weight-bearing joints are being worked, they get tired and they get painful. So once you go sit down and rest for a while, or you go lay down to go to sleep, then the pain should subside. Okay, so that would mean pain increases after exercise. When you wake up, you may have some joint stiffness, but usually it'll be less than 30 minutes or so, and then there won't be any more joint stiffness. And remember, this is specific to osteoarthritis because rheumatoid arthritis is kind of similar, but there are very distinct differences, and this is one of them. Again, with osteoarthritis, pain is relieved by rest, and joint stiffness in the morning subsides after less than 30 minutes. Okay. Eventually, joints can become tender to the touch. Inflammation can occur once that joint deteriorates. You may have some edema. Crepitus, which is like the crunching sound, the crackling sound when you use the joint, could happen. And with osteoarthritis, it is usually asymmetrical. So you can have it in one elbow and not the other elbow. You can have it in one knee and not the other knee. So you can have unilateral. Your body isn't going to be symmetrical when it comes to osteoarthritis. And again, here's our light bulb. Fatigue, fever, and organ involvement is not part of osteoarthritis. This is only affecting those weight-bearing joints. And then lastly, here in this picture, you can see some of these deformities that occur specific to osteoarthritis. We have Bouchard's node and Herberdine's node, both in the fingers. Okay, so when you hear those terms, Bouchard's node or Herberdine's node, think osteoarthritis. How are we going to diagnose OA? So we're going to get a good history and physical. We're going to ask a lot of questions, what's your occupation? What's your lifestyle? What do you do throughout the day? When does the pain worsen? What makes it better? All of those kind of questions. We're going to do a complete head to toe, and we're going to focus on those joints to see if we see those hallmark, telltale signs of osteoarthritis. We can do x-rays, bone scan, CT, MRI. Those are all imagings to detect early joint changes or figure out what stage and how much joint damage there is. And then there is no definitive lab result for osteoarthritis. You're pretty much doing labs to rule out other conditions that may be similar to osteoarthritis. When it comes to management, if the patient is obese, we're going to want them to lose weight. We want to rest and protect those joints. So we want to teach the patient to balance rest and activity. So they shouldn't stop being active, but they should include rest in their routine. We want to encourage rest periods of the affected joint, especially when there is acute inflammation. And you want to keep joints in a functional position with a splint or a brace if needed. However, you don't want to keep that joint immobilized more than 1 week because you run the risk of it becoming stiff because of that inactivity. We can use cold and heat therapy for these patients. So the heat can reduce pain and stiffness. Ice isn't used as often in osteoarthritis because it's non-inflammatory. But if the patient develops acute inflammation, later on in the disease, then ice would be appropriate. But generally speaking, osteoarthritis, you will use hot packs, warm bath, paraffin wax baths. We also want to encourage aerobic exercise. So aerobic conditioning, range of motion exercises, all of those things are aimed to support the muscles around the joint so that it can help with the, take some weight off that joint. For example, we would want to strengthen our core abdominal muscles if the patient has osteoarthritis in the vertebrae, so that the abdomen can kind of take some of that weight off the vertebrae. Surgical management, patients may opt for surgery or it may be required if the patient is suffering from disability and severe pain that's related to the osteoarthritis. This can be debridement of the area, a surgical fusion of the bone, or joint replacement, like hip replacement, knee replacement, that kind of thing. When it comes to drug therapy, we can offer salicylates, capsaicin cream, that's topical. We can do NSAIDs if there's inflammation, but we want to remember to be careful with those kidneys. Since this is a chronic progressive condition, you can anticipate the patient being on medication for longer periods of time, so we really want to pay attention to the organ function. Corticosteroids are appropriate, but be careful because we're talking about intra-articular corticosteroids. This means the patient will be getting injections of some type of steroid into the joint itself. So we're not taking systemic meds here. We're not taking something by mouth. It's not going into a vein. This is being injected directly into the joint. And then opioids are an option, but it is last resort. It is very, very rare that a patient with osteoarthritis will be on an opioid. So better just leave that one out. And then you can review table 20.1 in your textbook, pharmacological therapy for the treatment of osteoarthritis. It gives you a nice little overview. Whenever a patient is taking medications for pain, we want to be careful with constipation. So along with this osteoarthritis, when it's going to interfere with mobility. So if they don't have as much physical activity and they're taking these meds, we want to be careful with constipation. Next is rheumatoid arthritis. So you always want to keep them straight, osteoarthritis and rheumatoid arthritis, because they are different. So RA is a chronic systemic autoimmune disease characterized by inflammation of the connective tissue in the diarthrodial synovial joints. All right. So here we have chronic, okay, so similar to osteoarthritis, systemic. Okay, with osteoarthritis, it was only on the joints. but RA is systemic, which means it's going to affect the whole body. This is an autoimmune disease. Okay, autoimmune disease meaning that our body is attacking itself somehow, and there's inflammation. Okay, remember arthritis was non-inflammatory. Rheumatoid arthritis is inflammatory. And we're still talking about the same joints though, the diarthrodial synovial joints. Same joints, but different cause. So with autoimmune diseases, some antigen triggers an immune response. There's going to be synovial tissue damage. So that's what's going on. Our body is attacking that synovial tissue. There's going to be periods of exacerbation and remission, meaning that there's going to be flare-ups. Okay, so that is what rheumatoid arthritis is. All right, so risk factors: cigarette smoking, bacteria, viruses, and this is going to affect women more than men. The clinical manifestations of RA are going to be joint pain and swelling, so inflammation, erythema, redness. These patients will wake up stiff all over their body. All of their joints will be stiff, and it's going to linger. It's going to be more than 30 minutes, and it actually gets better with activity. So if you remember with OA, pain gets better with rest. With rheumatoid arthritis, pain gets better with activity. And the body will be affected symmetrically because this is systemic. So if you remember with osteoarthritis, it could happen just to one joint on one side. It can be mismatched. Rheumatoid arthritis, it's going to be on everywhere equally. So it's going to be symmetrical. Patient's going to complain of fatigue. There's going to be some inflammation in that synovium lining, synovitis in those joints. This RA is known for two deformities, the swan neck deformity pictured here and the boutonniere deformity. So when you hear those terms, then you know we're talking about RA. And this happens over time in the late stages of rheumatoid arthritis. This condition leads to irreversible joint damage and disabilities. So we want to make sure we slow this down and identify it early. Diagnostic wise, again, very similar to OA, we're going to get a good history and physical. We are going to do a head-to-toe assessment to see if we see any of those deformities forming. We can do x-rays. X-rays can show soft tissue swelling and some bone demineralization early on in the disease. But the emphasis here, the critical point of diagnostics, is to really determine that this is RA early on so that it can be treated, because as it progresses, it is going to cause this irreversible damage to the body. So continuing on, ultrasound, MRI, other imaging, blood tests. So we can do rheumatoid factor, RF, ESR, which is erythrocyte sedimentation rate, CRP, which is C-reactive protein, anti-nuclear antibody, and synovial fluid analysis. So all of these things are not definitive. They're just used in combination to try to figure out what it is. So we're going to do RF factor. We're going to do inflammation tests, which are ESR and CRP. Anti-nuclear antibody, which is ANA, will be positive. It's also positive in some other conditions. So again, it's not definitive. And if we took some of that fluid out of the joint, that synovial fluid, like if we took a needle and aspirated some of it out, it's going to be high in white blood cells. So that's another indicator that this is rheumatoid arthritis. And then here you can see in this picture on the right, rheumatoid arthritis can affect pretty much every body system. And you can see over time, it's going to cause all kinds of destruction. So now let's talk about how we're going to manage rheumatoid arthritis. So starting with nutrition and weight. So there's no special diet for rheumatoid arthritis, but we want to make sure they eat a balanced diet. So when they're experiencing the fatigue and the pain, and a lot of times they're depressed, that can cause a loss of appetite. They may not want to make food because they're too tired, or maybe the mobility has declined so bad that they can't really get up and prepare their own food. So weight loss is going to result from that. We want to encourage therapeutic exercise while incorporating rest and joint protection, very similar to osteoarthritis. We want to provide psychological support because, again, this can cause depression, isolation, withdrawal. Again, rest and joint protection, use of assistive devices, very similar to OA. So if they need a cane to help them walk, a walker, or even a wheelchair to assist them. Heat and cold applications. So remember, these patients are going to wake up very, very stiff, lots of joint stiffness, and heat is the magic for that. So we can recommend them taking a nice warm shower in the morning, and that can relieve a lot of that joint stiffness. Cold is for inflammation. Heat is for stiffness, relaxation. They also may opt to do the CAM approach, complementary and alternative therapies, so that's also an option for them. Reconstructive surgery, if there is a lot of bone destruction, they may need to replace a joint or may even have bone fusion. And then PT and OT can help with these patients. PT, to do exercises, safe for them. And then occupational therapist can also help preserve function and mobility of those joints. And then, of course, a social worker to help with resources and to help the patient have what they need at home. And then drug therapy. So these patients will take systemic glucocorticoids, steroids, which is different from osteoarthritis because remember, with osteoarthritis, they had injections into the joint of steroids. With rheumatoid arthritis, they're going to take them either by mouth or by IV, so systemic steroids. There's going to be pain medications, anti-inflammatories, because they're going to have inflammation. And again, we want to be careful when they take these medications long-term because it can affect their organs, especially the kidneys. And then disease-modifying anti-rheumatic drugs, DMARDs. This is specific to rheumatoid arthritis. Methotrexate is an example of that. Okay, so drug therapy, rheumatoid arthritis, DMARDs. And then there's 2 tables in your textbook that you can look at and review. Gives you a nice overview of those DMARDs and other biological therapy used to treat RA. So teaching. So because this is a chronic condition and there's going to be periods of exacerbations and remissions, it's important that the patient understands they need to take their meds and they need to be consistent, because if they stop taking them, they may have a flare-up. Because of the steroids, patients will be at risk for infection, so we want to let them know what to report, and they should report it early on. And if the patient does have an active infection, then immunosuppressive therapy should be discontinued at that time. And then we want to keep them healthy, so they should be vaccinated up to date with other vaccinations. You want to be careful with organ function, so you're going to look at the labs. These patients are also at risk for constipation because they're not moving a lot and they might be taking medications that are going to slow that GI tract. If the patient is on DMARDs, especially methotrexate, that can have a side effect of nausea and oral ulcers, so you want to be aware of that also. And here we have a select all that apply. Be sure to read through this and make sure you understand why those answers are true. Next we have scleroderma. So scleroderma by definition is a disorder of connective tissue characterized by fibrotic, degenerative, and sometimes inflammatory changes in the skin, blood vessels, synovium, skeletal muscles, and internal organs. So this isn't very common. There's about 9 to 19 cases per 1 million people a year. It happens between the ages of 30 and 50, and it's more prevalent in women than men. It is an autoimmune disease, and we're not exactly sure why this happens. And take a look at this picture here. It really does change the appearance. This is the same person before and after being diagnosed with scleroderma. So what is happening here? Okay, so on the left we have our normal skin, and on the right we have scleroderma. So right away you can see that the dermis here, this layer of the skin, is much wider on the right side. The fat has lessened and it's a little clumpy. And what's happening is there's a lot of collagen being produced, too much collagen, and it causes the tissue to become fibrosed and thick and hard. And in turn, the blood vessels in the skin, or actually not just in the skin, but wherever this is affecting in the body, they become occluded. Okay, so we have this ischemia that happens and this fibrous thick tissue. So there are two major types, which you'll see on the next slide. We are not going into depth about the categories of each. Just know there are two main types. One type is going to be cutaneous. It's going to be mostly localized on the skin. And when we say skin, it's going to be on the limbs, so mostly on the arms and the legs. Once this progresses to the systemic part or diffuse scleroderma, then you will see the trunk that has skin manifestations and the inside of the body, the organs. And that can include the lungs, the kidneys, the heart, and the GI tract can be affected. This is going to cause tissue damage, a lot of collagen formation. There's going to be loss of elasticity and movement, and the tissue degenerates and becomes non-functional. Okay, so that's the problem with scleroderma. Risk factors are going to include environmental or occupational because we're not quite sure what exactly is happening. This is a little chart of the types of scleroderma. Again, you don't really need to know this in depth. You just need to know there are two main parts. And again, the cutaneous is going to start off with the limbs, the arms or the legs. And once you see it go to the trunk of the body, then you know it's progressing to systemic, and the turtle organs and the inside structures will also be affected. Clinical manifestations, you can refer to the CREST syndrome. C for calcinosis, R for Raynaud phenomenon, E for esophageal dysfunction, S for sclerodactyly, and T for telangiectasia. Okay, so calcinosis is going to be this picture right here with calcium deposits not only in the skin but in the organs. So this is causing major damage. When it's on the skin, they're going to be these little bumps. They kind of look white. Raynaud's phenomenon is here pictured here, the second part. So Raynaud's, you can find it in combination with other conditions, but scleroderma, it also happens. So the little vessels in the fingers start to spasm when triggered by heat or cold. So you can go outside, and if it's cold, if there's like a breeze, then those little vessels kind of constrict, spasm, and they cut off blood flow, and that's what you see, this white. And it happens with heat also. Esophageal dysfunction, patients could have difficulty swallowing, dysphagia, and heartburn. Sclerodactyly, fingers curl inwards. It's like this picture here. And that's because that skin has gotten so tight and thick. Telangiectasia are red thread-like marks on the skin, and you can see one here on the nose. This will be all over the skin. Diagnostics. So we're going to get a good H&P, history and physical. We're going to do a complete head to toe to see, if the skin has been affected and where it is, because location matters. It kind of gives us a hint if it has transitioned into the systemic sclerosis. We can do antibody testing because this is autoimmune. We can do a nail bed capillary microscopy, chest x-ray, biopsies, urine analysis, pulmonary function tests. So these patients are going to be high risk for infection. They're going to be fatigued. They may have delayed wound healing, and they're going to have chronic ischemia all throughout their body. And for this one, unfortunately, there's not really one way to treat these patients. So it's going to be based on which organs are involved and what signs and symptoms the patient has, and that's how it will be treated. So medication-wise, these patients are taking systemic steroids and immunosuppressants, so very high risk for infection. Antihistamines, some topical ointments, and vasodilators, because remember there's that ischemia, so we're going to try to open up those vessels. Ultimate complications are going to include infection, renal failure, because those organs are going to be affected, heart failure, pulmonary fibrosis. The tissue in the lungs is going to become hard and stiff, and the patient can die from progressive severe scleroderma. Okay, so we don't want that. Nursing wise, your interventions, you're going to give those medications as ordered. You want to provide range of motion. You want to refer these patients to specialists, because if they have severe organ damage in one or more organs, we want them to have specialized care. And then these patients will benefit from counseling so that they can get us the psychosocial support they need there also. And here's another NCLEX style question for you that you can look over. Moving on to lupus erythematosus. So systemic lupus erythematosus is SLE for short, and this is a multi-system inflammatory immune disease. So let's break that down. Systemic, total body, multi-system, it's going to affect us everywhere. Inflammatory, you're going to have inflammation, and it's autoimmune, so that means they're going to have periods of exacerbation and remission. So this typically affects the skin, the joints, and serous membranes. Eventually, as the disease progresses, the kidneys can be affected, the blood can be affected, neurologic systems are affected. This involves a chronic, progressive, unpredictable course, again with remission and exacerbation. So this is lifelong, and it can be devastating for some people. And just for your knowledge, there is also a cutaneous lupus erythematosus, or CLE, which is only localized to the skin, but this actually eventually progresses to the systemic type. Okay, so risk factors for lupus. It runs in families sometimes, and females in the childbearing years 15 to 40 are high at risk of getting lupus around that time. Also with pregnancy, so especially in the postpartum time, you can get an exacerbation of lupus, so that should be included in your teaching. Ethnicity plays a role. African American, Asian, and Hispanics are at higher risk for getting lupus. Smoking, UV light, so the sun, major surgery, and some medications can also trigger that. So clinical manifestations, there is no pattern, which makes it kind of difficult to diagnose at first. Everybody's different. What they present with will be different. So a good history and physical is really important. But the general complaints that most patients will say is fever, weight loss, joint pain, and fatigue. Okay, which is very different from the others. This has fever, weight loss, excessive fatigue. Okay, so different from the others. Patients may also have a malar rash or butterfly rash, and that is on the face, kind of looks like a butterfly. And other signs and symptoms would be difficulty concentrating, photosensitivity, so that means sensitive to light. They can get oral or nasal ulcers, dry eyes and mouth. Hypertension, okay, so once this starts to affect the kidneys, they can actually experience malignant hypertension where it's a medical emergency. So remember lupus, hypertension, and can also cause leukopenia. Leukopenia is low white blood cells, okay, and also thrombocytopenia, low platelet count. So if you have leukopenia, that means you're high risk for infection, and if you have thrombocytopenia, you have a high risk for bleeding. Diagnostics, again, good history and physical, ask a lot of questions, do head to toe. There is no definitive test, so we're going to do the basics. We're going to run a complete blood cell count, which is a CBC, and we're going to see pancytopenia. We're going to see low everything, low WBC, low platelets, and low red blood cells. BUN and creatinine, that's to check the kidney function, and because this is an autoimmune disease, we're going to check those antibodies. We're going to check serum complement, so that will be more familiar with you when we talk about our inflammatory and immune response. A UA, we can get x-rays of the joints, chest x-ray to see any changes there, and an EKG to see if the heart has had any effects from that. Listed in this gray box is the criteria to classify as having lupus. If you have 4 or more of the criteria here, then you would be considered diagnosed with lupus. However, even if you don't have 4, they'll typically still diagnose you with less than 4 if the signs and symptoms are, pretty significant. So complications, this is going to affect the whole body, so you're going to have all kinds of organ involvement: renal failure, heart disease, lung disease, hypercoagulation, stroke, issues with the joints, increased risk for infection. We can use NSAIDs for mild disease, steroid-sparing drugs, methotrexate, So what that means, steroid sparing, is because we can't always use corticosteroids for long periods of time at high doses because it has side effects. So if we pair it up, a corticosteroid paired up with a steroid sparing drug, then we'll get the same result with less medication. Some anti-malarials, hydroxychloroquine is an option. So immunosuppressive drugs, to calm down our immune system because it is an autoimmune disease, though that can work also. Teaching and management, this is lifelong, it's chronic. We want to identify triggers that the patients have, and we want to make sure that they are adhering to the plan of care and medication use. Avoid prolonged sun exposure. This does not mean that they shouldn't go in the sun. It just means they shouldn't be out in the sun for long periods of time. There's a difference. They should have frequent rest periods, make sure they get good sleep, make sure they're immunize. Make sure they have their immunizations and that they don't get a live vaccine because of the risk for infection for these patients. And again, because it affects multi-organ systems, we should be referring them to specialists so they can get that focused care. And surgical management, if there is a lot of severe damage to, for example, the kidneys or the joints, then they may need a transplant or some joint replacement. Here's another NCLEX style question for you to practice. And now we're moving on to gout. So gout, by definition, is a type of arthritis characterized by an elevation of uric acid, which is called hyperuricemia, and the deposit of that extra uric acid, those little crystals, in one or more joints. So here we have a picture of uric acid crystals under the microscope. You can see they're long, thin, and sharp. So when they start to accumulate in the joint, it can be really painful. And the telltale sign is inflammation of the great toe that you see here, which is called podagra. Very, very painful. So gout is usually, it comes with flares, flare-ups, and then asymptomatic. And the flare-ups can last from days to weeks. And then in between flare-ups, it can be a long time, months, even years without a flare-up. All right, so why does this happen? So we have too much uric acid in the blood. That can be for a few different reasons. Either the kidneys are not working right, they're not, filtering out that uric acid, or maybe there isn't, for some reason you have so much uric acid, the body just can't handle getting rid of it. So whatever the problem is with the kidneys, we're not going to talk about that. That's a whole nother chapter. So we're just going to deal with all of this uric acid. Okay, so where does uric acid come from? It is the major byproduct of purine catabolism. So the breakdown of purine. So what has purine in it? This picture here: organ meat, red meat, seafood, sweetened beverages, and alcohol. All alcohol, but especially beer. Okay, so there's your teaching. These patients should really limit their intake of all of these things, or better yet, don't even eat them at all. Okay, because once you eat those, you consume those, they're broken down into purine, and then purine is broken down into uric acid, and then all of those crystals start hanging out. They go to your joints and they cause gout. Okay, so not everyone with high uric acid levels is going to develop gout. So maybe you go to your doctor and your uric acid levels are really high, but you don't have gout and you won't get gout. So that's not a definitive blood test to diagnose gout. However, if you come in and your big toe is huge, podagra, and you're obese, and we ask you and you drink a lot of beer, and you have high uric acid levels, okay, yes, then we're going to say you have gout. So risk factors: obesity, hypertension, eating foods that have a lot of purine, thiazide diuretics specifically, and of course drinking a lot of alcohol, especially beer. So there's 3 phases of gout. We're going to have the acute, the intercritical, and the chronic. So during the acute phase, you're going to have at least one joint affected, and there's going to be a lot of pain, acute onset of pain. There's going to be redness and swelling. So we're going to have inflammation. Then we have this intercritical phase. This is where the patient's asymptomatic. So this is in between those flare-ups of the gout. Then we have the chronic phase. So this is when the patient has had this for years. They've had attacks come and go, and this eventually will lead to tophi, which is pictured here. This is the deformity for gout. Tophi, when you think of tophi, think of gout, and joint destruction over time. Okay, so gout can also lead to irreversible joint damage. Clinical manifestations, the most common is going to be inflammation of that great toe. And when we say inflammation, it's all of those things: the redness, the warmth, the edema, the pain, the loss of function. Whatever other joints are affected can appear dusky or cyanotic and very, 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 very painful. And then once that flare-up goes away, patient will be asymptomatic between attacks. And again, there's that tophi word. Okay, that is a deformity. These little uric acid buildup, and they form these deformities here that I'm circling. Diagnostics, H&P, we're going to get a good history. Are you drinking a lot? You know, what are your habits? What are your lifestyle? A head-to-toe assessment, we're going to look for signs and symptoms of joint pain and swelling, inflammation, and that tophi. The only definitive way to diagnose gout is to aspirate fluid from the synovial compartment there where the two joints meet, and then you'll see the presence of uric acid crystals. But that's not necessary to diagnose. It's very rare that they do this to diagnose gout, because you can just do the H&P and then you can see the great big toe is inflamed and you can pretty much determine the patient has gout. We can also look at the blood levels to confirm that. So serum uric acid above 6 milligrams per deciliter, mg/dl. Okay, again, not definitive, because you can have high uric acid and still not have gout. Teaching. Well, we already know our risk factors, so whatever's modifiable, that's what we want to modify. They should lose weight if they're obese. They should avoid alcohol, especially beer. Whenever we have things that build up in the blood, like this uric acid, the kidneys aren't able to filter. We want to keep hydrated. We want to dilute the blood. So adequate hydration is important. Proper nutrition, again, that's education on purine, keeping the purine out of your diet. Splint the affected joint, that can help with immobility so it can have time to kind of rest, joint protection. And then there are some triggers like fasting and medical events that can actually make gout flare up. Medical events would be like an illness or maybe a surgery. Treatment. So the point of, or the focus of treatment during the acute phase would be to decrease the pain and inflammation. Okay, we're not trying to cure the uric acid levels. We just want to make the patient comfortable. That's going to be by way of NSAIDs, okay, and steroids. So that is going to be our go-to for the acute phase of gout. For the intercritical, which is going to be that asymptomatic period, if needed, we're going to give NSAIDs and we're going to give colchicine. So colchicine should not be given during the acute phase because this medication is uric acid lowering. It's a uric acid lowering agent. Okay, same thing with allopurinol and febuxostat. Those are uric acid lowering agents which reduce the amount of uric acid in the blood by inhibiting the production of uric acid. So we're not going to do that during the acute phase, and for some reason, we're not sure, when you change the uric acid levels in the blood really fast, it provokes or worsens the gout. So we don't want to do that. So in the acute phase, we're just going to focus on decreasing the pain and inflammation. In the chronic phase, that's when we're going to try to reduce those uric acid levels so we can prevent further attacks in the future. Okay, another NCLEX style question for you. Next is fibromyalgia. So fibromyalgia is a chronic central pain syndrome marked by widespread non-articular musculoskeletal pain and fatigue with multiple tender joints. So let's break this down. So this is chronic, so they're going to have it forever. They're going to have it long term. Central pain syndrome. So we see the word central, so this means our brain is involved, and syndrome. Whenever you see the word syndrome, it's kind of non-specific. It's just a group of whatever they're talking about kind of mosh posh together. So it's not like definitive. So it's a syndrome marked by non-articular musculoskeletal pain and fatigue with multiple tender joints. So the pathophys on this is unknown. They're not really sure why some people experience this fibromyalgia, but it is a chronic pain disorder of the soft connective tissues, and it can also cause insomnia, fatigue, stiffness, and cognitive dysfunction. So the patient may not be able to focus on tasks, stuff like that. And there are some theories about what exactly is happening. One of them is that there's some type of abnormal processing of external stimuli, and normal pain is amplified in the brain. So that's one theory. So these patients feel pain where people that don't have fibromyalgia wouldn't feel any pain. And this can be triggered by an infection or some type of physical or even emotional trauma. In females, it can be triggered by the menstrual cycle, and the menstrual cycle can affect the sensitivity to pain. So that may indicate that hormones are also involved. So risk factors for fibromyalgia include rheumatoid arthritis. So if you have RA, if you have lupus, if you have Sjogren's syndrome, sometimes this runs in families, and if you're female. Again, this is a syndrome, very non-specific reasons, non-specific manifestations. So on to clinical manifestations, you see that generalized musculoskeletal pain. So if a patient comes into the doctor's office and they say, well, I just have muscle pain, that can mean so many different things. So often it takes a long time for patients to be diagnosed with fibromyalgia. Other signs would be stiffness, malaise, which is just not feeling well, fatigue, again, those cognitive problems, difficulty concentrating, difficulty focusing, headaches, trouble sleeping, depression, anxiety, fever. Okay, so this is fibromyalgia. And here in this picture, you can see the most common points that people with fibromyalgia complain of. So the neck, here, the knees. Okay, so patients with fibromyalgia might complain of, tender points in the knees. Okay, so you would expect that. Diagnostics, again, H&P, we have to ask a lot of questions, and there's no definitive test, so we're just going to do a bunch of labs to rule out other diseases that may be similar with similar signs and symptoms. Management-wise, very similar to the others, we want to do physical therapy, strength training, aerobic exercise, again, to strengthen the muscles around joints and areas that are affected. Cognitive behavioral therapy to help with those cognitive issues they may be experiencing. Lots of education and self-management skills, only because this is lifelong, and this can be, this can affect your ADLs. So medications, serotonin, norepinephrine, sleep aids, and non-opioid analgesics. Remember, non-opioid for fibromyalgia, really important. Patients with fibromyalgia are going to have chronic pain, and the reason why we don't use opioids is because, or they're not recommended, is because they can be habit forming, and they're usually ineffective for this type of pain anyway. So important, fibromyalgia, no opioids, okay? Only non-opioid analgesics. Here's another NCLEX question for you, and this will conclude this module.